Welcome to today's webinar organized by Department of PMR, SVNIRTAR, under the aegis of IAPMR. Friends, besides medical rehabilitation, social rehabilitation plays important role in spinal cord injury rehabilitation. Out of that, sexual rehabilitation is often ignored. Both physician and patients, they feel uncomfortable to discuss about the sexual issues. So to discuss regarding sexual rehabilitation, today we have invited one of our colleague, Dr. Abhinav Singh, Assistant Professor at ESIC Medical College. At this young age, he has lot of credits to his career. He is a prestigious member of Rehabilitation Standard Committee of Asia. He is mentor in International Continent Society. He has also contributed a beautiful chapter on aerodynamics in our official textbook of IAPMR. He is very much instrumental in starting cancer rehabilitation clinic in Bihar. He is a member of special interest group for cancer rehabilitation in ISPRM. He has lot of oral presentation and poster presentations in various national and international conferences. So he's also a lot of contribution towards during the COVID period. He has worked hard in different situations in COVID management. So he has a vast experience on that. I have heard about him. So without wasting time, I welcome Dr. Abhinav Singh for your presentation on sexual rehabilitation in spinal cord injury. Over to you. Dr. Abhinav, you can start your presentation. Hello. Arun? Hello?
Sir might be offline, sir. His video is not coming and he disconnected, sir. He might be trying to connect again.
In the meantime, you can switch up the recording. We'll start once his presentation started. So you can start now.
Sure, sir. As usual, there's something called performance anxiety, which is quite common. And I think I also had the same by performing there on the screen.
No, it's not like that.
to perform in the webinar, not in that other way around, sir. So this topic is very crucial, this sexual rehabilitation in persons with a spinal cord injury. If even we remove this word, first word in the slide, and continue only with the rehabilitation, so whatever complications we face or whatever challenges we face during rehabilitation will also be faced during this part also, this part of the rehabilitation, whether it is a pressure injury, whether it is heterotrophic ossifications, whether there is a risk of fractures, whether there is any complication that comes to our mind for a person with a spinal cord injury, which we try to sort it out, even including bladder incontinence, bowel incontinence, fissures, everything matters in this type of patients. So every aspect of rehabilitation is included, although many a time we tend to miss this topic. And so today we will be discussing this. Now, this photograph everyone can see, and this is my disclaimer also. What we can see in this is the last line, a sexy imagination. This is an advertisement of something which we put on our nose. But many of us would not have noticed that the spectacles or the goggles that we use. And so that is the problem with this. This is an advertisement of a Ray-Ban company. Ray-Ban goggles that is being used commonly. But what is attracting us? Nowhere on the face. It is something else. But this is a part and parcel of our life. And everybody has this imagination at some point of time. And if someone says he does not have, then it is quite difficult to believe. So this Ray-Ban advertisement is itself a proof that everyone has need it at some point of time. Why do we need this? We need this for getting an emotional attachment, for the requirements of our hormonal needs. It is also a cultural requirement. Other than that, the scene from the movie Kabir Singh, physical needs to machoism or to show it that everyone has it at some point of time, needs the culture grows like that. And the different cultures have their different preferences and different way of communicating or passing on this, managing this problem of the sex. What are the benefits? The main benefit is the immune system. Immune system becomes strong. As you know, many of our patients, most of our patients are immune compromised at some point of time. They are weaker because of the injury as well as because of the lifestyle that they develop in due course of time. Best example is many of them will have hemoglobin around 10, 10 or 11 or lower side of the hemoglobin because they are malnourished. They have to manage with a limited food. Bowel and blood issues. Bowel issues are there that always keeps haunts in their mind. Their immune system is compromised, but this do help in. Another psychological aspect that helps is building the self-esteem, which once if someone is able to perform, it helps in the personal growth, self-care, self-acceptance, and resilience. They prefer to positive talk about themselves and the healthy boundary. Another common problem with patients with a spinal cord injury is these: anxiety, stress, frustration, depression, low mood, sadness, hopelessness. These all things come out. But if this part is managed, sex is managed, then these issues can also be sorted out in due course of time. Another thing is because of good sex, if someone is having, he gets a good sleep. That relaxes the body. That is an important part for any person's life to manage his day-to-day activities. It also develops intimacy with the partner. It can be of different types: physical, intellectual, experimental, emotional, spiritual. On a lighter note, I can say all those who have watched porn, the common thing that is the spiritual part, you hear more less at the religious place, more in the porn. So there are a few of these studies. You can understand how the sexual rehabilitation part is missing from world over. That this 2024, I searched what are the latest publications. Now the people are still discussing this. It's not, it cannot, can we do this? It's how do you feel after doing this? A critical discourse analysis of sexuality support after the spinal cord injury. Because this sexual rehabilitation of the spinal cord injury is something which is missing in the medical world. And this is another article which was published in 2022, Elephant in the Room, Integrating Sexual Health Practices, Spinal Cord Injury Rehabilitation. In 2022, we are still discussing about whether it has to be integrated or it does not need to be integrated. Right now, most of us must be practicing it, must be integrating it. It is an integrated part of the rehabilitation and the rehabilitation process that is happening. And female, although the prevalence of spinal cord injury is less in female world over, but still this is something which is missing. And this is a very good article which was written in 2005. What are the sexual, what do women want? And if you look into the result of this, you will find that only 2 women report receiving in-depth sexual rehabilitation services, because sexuality was not a priority soon after the injury for majority, but assumed greater importance later. This is an important thing. Immediately after injury, it may not be a priority, but later on, as one gets rehabilitated, it becomes an important part. Now, there is another type of good study that was done and published in Topics in spinal cord injury rehab, that whether how the sexual activity differs in adults with who had spinal cord injury in the pediatric onset, and followed by demography and lifestyle factors. And this is an interesting study, because those who had this spinal cord injury pediatric onset has a better sexual life, a better physical intimacy, and almost 50% of those patients that were included in this study had a good physical intimacy, compared to the about 50%, about 40-45% of these patients had a good intercourse. That is what reported. Intimacy is completely different and intercourse is completely different, which we have to agree with it. Now, why this colaveri? Right now, I will be discussing more of a male part and later on with the female part. Treat her right or eat her right, it is for everyone to decide. And this is from one of the movie, Love, Sex or Dhokha. Why this dhokha? Infidelity is very common in the patients with a spinal cord injury. They find it difficult to manage it at some point of time. What I do commonly prefer while counseling these patients is, it is just like our need, another need, as we need to pass our urine, and we need to go clear our bowel, as we need have an appetite. It is another type of appetite which God has given us, and it has to be fulfilled by one and all and everyone. What is the purpose of this sex? Why we need it? We need it for recreation and procreation. Recreation means for the pleasure. Procreation means for the reproduction. If, in another word, if I have to change it into scientific terms or the medical term, this recreation part or the pleasure part has more to do with the parasympathetic part, and the procreation part has more to do with the reproductive ejaculatory part, or the reproduction, for which we need an ejaculation in the male. So this is the male purpose, and always we have to remember this erectile part and the ejaculatory pathway are completely different. They have a different mechanism of action and way of acting, because this ejaculatory part is mainly concerned with the T2, T12 to L2 part, L2 region, if that is the sympathetic pathway. So, and this is a parasympathetic pathway or somatosensory pathway that has to be taken care of. Now, when to start the sexual rehabilitation? Answer is simple: ASAP, as soon as possible. But how is it possible? The moment patient comes to us, visits a department of PMR, he is bedbound, he is on Foley's catheter. So how to do it? The first and foremost thing that you have to do it is, and we do, is setting the goal, counseling the patient. What are the goals? So during the counseling, it is an important and integral part that we have to include it. The moment you start discussing this part, you can see the change in the face of the partner as well as the patient. And that's why counseling is the most important part. Psychogenic part has to be always taken care of. Time is very precious. Another thing is, suppose patient side counseling part is done, then what? So the another target will be, these will be the requirements. Foley's catheter, it has to be out. That is another important thing. Then comes the trunk balance. We do need a good trunk balance. If patient is unable to manage it, we have to look for the other supportive measures to give a good trunk balance. Another thing that is important that has to be kept in mind while managing it is the UTI. This recurrent UTI is very common in this type of patients. So UTI has to be resolved, because we may end up infecting the partner. Another is the taking care of the spasticity part, and if possible, take care of the hand function as much as possible. Why I'm saying about this hand function is because I'm again telling because it is the most integral part, because to satisfy a partner, one needs a good foreplay. Foreplay is the most predominant part and it is well documented everywhere. Suppose for an intercourse, one needs 5 minutes. For foreplay, you need to have spend at least 20 to 25 minutes. 5 times you have to spend. Then only you can get a satisfaction. And another important thing that one has to keep in mind is that for other than satisfying each other's, for a female to develop orgasm, you always need it is always a slow process. In male, orgasm is comparatively fast, so that has to be taken care of, and that's why foreplay becomes important. Now, what are the prerequisites for intercourse? Clean. We have to always keep everything clean. Clean area. When we say clean area, it means clean bed and clean pelvic area. That means the hairs should be removed, because these hairs in the pelvic area are a good source, a good area for a humidity to develop. First thing, many of our patients are at risk of having bladder incontinence or bowel incontinence. So these are the good area for any microorganism to develop or to develop. So this may end, patient may end up transferring that infection to the partner, and bowel and bladder has to be always empty, because at some point of time, because of the change of position which patient was doing earlier needs to be changed. So bladder has to be emptied. If someone is sitting on the lower abdomen, patient may have the leak, so we do advise that patient should go for the clean intermittent catheterization, and bowel definitely needs to be cleaned and managed. So, if someone has seen Kabir Singh, I think all over India people have seen Kabir Singh in their language. Every language it is there, Telugu, Malayalam, and everywhere. So this part of the movie, if you remember. So remember it. This clean is the another prerequisite. Suppose a patient is unable to sit, then what can be done? So there is a need for modification, wheelchair modifications. There is an important and integral part, because most of the time we are providing a customized wheelchair. So if someone is not having a good trunk balance, is not able to sit properly, so these modifications can be planned in the wheelchair. So, and as the technology is advancing, more motorized component that can be managed with hand and can be done, and it has to be always taken care of. Now, another question is, does level of injury matters? Yes. For erection and vaginal vasocongestion, there are two things that matters: psychogenic and the reflex. Now, if for another that we have to always keep in mind, the sensory scores, pin prick and light touch, that is very important in these type of patients, because if the sensory scores are present, especially from T11 to L2, then this patient will have good psychogenic erections or the vaginal vasocongestion. This has to be always there in mind, and we have to always examine it. Another important aspect of the sensory scores or the pin prick and the light touch is whether S4, S5 or the sacral region and the vulvocavernous reflex is present or not present. If it is absent, then reflex will be absent. Reflex, erection and vaginal vasocongestion will be option. Then what about the orgasm? 40% of patients do have orgasm in a spinal cord injury, whatever the level as per the documents, but it is many a time it gets delayed orgasm compared to the normal population. So again, always we have to keep this thing in mind, T11 to L2 part and this. So this is the most important part, nitric oxide, medication, everything depends on the GTP and the CGMP, calcium, muscle smooth relaxations has to be kept in mind. So what are the functions that is being done during the intercourse? Erection, emission, and the ejaculation. This part is predominantly parasympathetic part that is will be working, and in the ejaculation it will be mostly the sympathetic part, and in between will come the emission part. So if someone is having this erectile dysfunction, what can be done? 2-3 options that we have: oral medication, which is most commonly prescribed. Then comes the vacuum devices, then the intracavernous injections, then comes the penile implants. Intracavernous injections and the penile implants. This vacuum device, it's a really works, but and in 50% of patient, it gives a good erection. This is the data which mostly I took it from the Bradham only. And but the problem is this constriction band that is there at the vacuum device. So because this can lead to formation of ulcers and other complications, and so we have to make sure that this is not vacuum devices is not used for more than 30 minutes. So or has to be always kept in mind, and it is easily available. The cost of this vacuum device is around 2,000 to 5,000 rupees. Now, inflatable penile implant, I have not seen till now. This 10%, it has got very good result, but this 10% complication rate is there. And these complication rates are very detrimental for the patients. These detrimental things are mainly this injury to the skin and the recurrent infection that happens to the urethra. So penile implants are not commonly used, not used commonly. Now comes the oral medications. These are the 4 oral medication. This is the first one is the easily available. Even Pan Ka Dukan has this. Anyone can go and have it. But one problem with this is if it is a male patient, female find it difficult to go and ask for it. So at some point of time, we do prefer to use tadalafil, although it has another benefit also. This is a fast acting and it lasts for 4 to 6 hours, and it has a better absorption in empty stomach. That is, and it is affected by its absorption is affected by the fatty food. Vardenafil is same as the sildenafil, but it is not affected by food. One thing is, it can be even taken with the fatty food. Tadalafil, it is a very long acting, it works up to 36 hours, and it is not at all affected by any type of food which we take. And it can cause, one of the common complication is it can cause muscle and back pain. Avanafil, although not that much easily available compared to tadalafil and the sildenafil, because it is better and it has lower rate of side effect compared to these three. This tadalafil is also called the weekend pill because of this long acting duration, 36 hours. Now this, if we use it judicially and with a proper dose, 75% of erectile dysfunction can be managed in persons with a spinal cord injury. 75% if properly used and managed. Now this is an interesting case which we saw in IGIMS. This was a 25-year-old Mr. XY. XY was his chromosome as well, with T10 complete spinal cord injury. He came to us and he said he has a girlfriend and he wants to marry. Can I marry? I said, yes, you can marry. There is no issues. Then he said, but I am having this erectile problem. Can I expand my family? I said, yes, there are multiple options. They got married. He is a Paralympic player as well. They got married. And now he came to us and we tried this oral medications in optimum doses. But this oral medication, unfortunately, did not work in this patient. It did not work. Then we have to plan for something called penile injection. This penile injection commonly had a very good success rate. 90% of patients will have good erection with it. But the problem with this is where to give, how to give, and patient has to be trained properly. So the best place to give is 2 o'clock and 10 o'clock, or between 11 to 8 or 2 to 10. But this is where the corpus cavernosum is present and we can insert it. Now the standard treatment protocol for this penile injection is to give it at one site Single side, alternate. One day if you are giving on the right side, other day you have to give on the left side. Please, and it is always advised, don't give it posteriorly, because posterior side there will be urethra and it is just waste of medicine. And there will be nerves and all, nerve bundles, so it may not work. So this is the optimum side. This patient about which I was discussing, we tried single side. Papaverine was tried. There are other options also, but papaverine is an easily available and easily accessible. That's why we tried. I tried first with 20 milligram, but it didn't work. Then I went up to 30, 60, 70. It did not work. Single site I tried. Then I tried in double site, 35 each, and it worked. Then I told him, okay, just try it on the double site. Yeah, and let's see. And we tried it in the we have a room in the IJMS OPD. Besides, we gave him all privacy. Wife was there and everything was there. Then he came for follow-up after 1 month or so. And I asked, how is it? He said, I'm having a good time. I said, okay, how long are you having this erection? And he said, 2 hours. I was gone mad. How come? This was having 15 minutes, 10 to 15 minutes and that of erection in when we tried, and how come it happens to 75? Then after talking with him, taking history again and again, I realized that when the same person was in our OPD and it was room, that privacy was compromised. It was not at all that much comfortable, and that comfort level has compromised his has raised his level of anxiety, and everything was compromised. And the moment this gentleman went to home, he's having, and slowly we have to decrease the dose. Right now he's at 20 mg. Now this papaverine is available in different compositions. This is a trimix, even quad mix is available by papaverine and phentonalamine and prostaglandin E1. Smooth muscle relaxant is the papaverine, phentolamine is the vasodilators along with the prostaglandin and different composition, and it is showing different results. But because most of our patients are coming from remote areas, these two are not available. Even in Patna, I could not find it at. It is not available at all the shops, and patients are not comfortable ordering online. Online, there are a lot of issues. India Mart, and these are the photos from the India Mart. So this papaverine injection uh, always comes in a small vial, and we have to teach them. So if that patient has a 2 hours of erection, he was always at risk of priapism. Another issue is scar tissue. A scar can develop, and if he is having it, so there are some point of time we have to be careful while prescribing these injections. One is we have to always tell them about this risk of priapism, and if it is there, go and plan for masturbation. You can try eyes and different aspects. Another thing with this is the scar tissue that patient may develop if he is taking repeatedly at the same point. So it is always advisable to have a gap of at least 24 hours between two injections. First thing, to prevent this scar developing in the penile area. Another thing is to have it, how frequently to have it. It is four times, 3 to 4 times per week is enough. My patient was having it once in a week or two, because he was a sportsman and he has to travel a lot, and that privacy was not available in the a sports complex and anywhere he was moving. So these are the things that we have to keep. I do prefer pepfavirin, but if I get a chance, I can eat. And trimix and all are very costly. This cost around 10 to 15 rupees only, and it can be given even with the insulin syringe. That's it. Now another thing is ejaculation part. Uh, there are three things that can be done: manual or by partner masturbation. It can be tried. Penile and vibratory stimulation and electro-ejaculations are the things that can be tried. This ejaculation is present in 10 to 20% of patients with a spinal cord injury. Rest all, it is mostly compromised in one form or the other. So this electro-ejaculation, it is done in the through the anal rectal area near the prostate, and it is stimulated with different frequencies, and it is being done. And one more thing, when we are trying all these things, we have to keep one thing in mind, is that these patients are at risk of retrograde ejaculation, and this may become a foreign body inside the bladder, and it may lead to recurrent infections. That has to be always we have to keep in mind. Another thing is this when patient is on long-term CIC, these patients may develop false passage. So whenever ejaculation is happening, this sperm can go and deposit in the those false passages inside the urethra, small pockets inside the urethra, and that may lead to the decrease in the quantity. So 4 ml becomes a bit difficult. It is also said that the quality of a sperm keeps deteriorating with the duration of injury or time of injury. So that is another problem that has to be cleared. This is one of an interesting study done by Sivaram. Dr. Sivaram is, you can call him my guru, who taught me about sexual rehabilitation in CMC Vellore during Chai Ka Charcha. And it is a very good study, whether the clinical predictors of vibrator assisted ejaculation following spinal cord injury, and it was an observational study. And in this study, they found that this level of injury does matter. And in most of the patients were T10 and above, and or T10 and below. So this sympathetic part was compromised, and this vibrator assisted had a good outcome in those patients. And this is the penile vibrator that was being used. It is study says that it produces superior sperm quality, and it is more comfortable and preferable to the patients. 60 to 80% of chemicals. It can be assisted with midodrine and vardenafil. But whenever we are using this, we have to always be cautious, because we have to look for the autonomic dysreflexia, especially in those patients who are T6 and above. Injury is T6 and above. There is always a risk, because this stimulus may be a noxious stimulus for them, and patient may have it, and we have to keep changing and managing those needs, because AD, as you know, it is an emergency. Now, the fertility in female, about 4 months post injury, most of the patients will have temporary amenorrhea. With pregnancy, as if a female pregnancy hormonal changes are more or less insignificant. It is with the spinal cord injury, because it is more it is said, it is no concrete evidence is there that the hormone secretions and all will change in a female after the spinal cord injury. Few are there, but these are only case series. So if a female becomes pregnant, the issues that comes up is the transfer. If she has to transfer from one position to another, from bed to the wheelchair, it becomes difficult, because she is going to gain weight in due course of time. And also she finds it difficult to perform the pressure relief measures, which we teach them during the rehabilitation. Every 20 to 30 minutes they have to do the push-ups and all. And also most of the patients do get customized wheelchair for a good rehabilitation. So if someone puts on weight, the propulsion of wheelchair becomes difficult, transfer becomes difficult, sitting in the wheelchair becomes difficult, and these patients are prone to develop pressure ulcer in due course of time. That has to be always keep in mind. Another problem that they find is as pregnancy progresses, they do tend to develop fat in the, or do tend to gain weight, and especially in the lower abdomen and the thighs. So doing CIC becomes challenging in these patients. So all these things are the points that we have to keep in mind, keep adjusting as per the teaching the patient as per their need, and everything has to be customized. Another problem with these patients are, if patient is above T6 and above, then again risk of autonomic dysreflexia has to be always kept in mind. Now, is this something, can you see something after labor, anyone? It is a written pain or the dull, because most of our patients don't feel that pain. because of the labor. So labor pain, if it is there, so again, for the labor pain, it can exaggerate the spasticity and it can exaggerate the autonomic dysreflexia. Two things that has to be always kept in mind. Another thing is, it is always advised or preferred to go for LSCS rather than waiting for a normal delivery, because the lower abdomen is on the weaker side. So these patients may have complications or preterm deliveries, chances are there. And if a patient has to undergo LSCS, the anesthesia that is preferred is the epidural anesthesia, because that will also help in managing the autonomic dysreflexia part also. So this is background of my building where I am working. So it is a fact that humans do love sex. We need sex. It's how we connect it, remind us where we live, and it is the third most basic human need after food, good movie, popcorn. Always we have to keep this thing in mind. So this is all about my talk. And in the meantime, I will go through this. During the IAPMR group, Kaustubh sir and Naveen sir from Pondicherry has said that how I'm sensitizing the patients and the medical fraternity about the rehabilitation, Jhola Chhap rehabilitation that is happening everywhere. So I have put 2 slides for that. If Sahoo sir permits me, I will show that.
Yes, you can go ahead, please. Please go ahead.
So, this is a viral video.
I think there is no audio to this videos, no?
Sir, this audio is visible, na? Oh, audible, na? This audio.
Yeah, audio is not audible, but video we can see.
This video, I have switched it, unmuted it,
Okay.
because this is a practitioner who is giving some therapy, and he has been charging some $300 daily from this patient.
What is the patient condition for which he is giving therapy?
Sorry, sir.
What is that patient condition? Do you have any idea about the condition of the patient? What type of therapy is giving?
No, no idea. This is what is happening. Jhola chhap, sir, treatment.
He may not be a physiotherapist.
No, sir, he is not at all a physiotherapist. More, he is someone who was trained in some physiotherapy center, and then he started claiming, and if there is a complication, he will send these patients to that physiotherapy, and just like a quack who is working in the remote area,
Right.
they will do it. And the outcome of this patient is in the next slide, sir. This is the outcome. That's sir. Many times what happens, we will counsel the patient will go out of the PMR OPD, and he will end up in those places that I will make you walk. And these doctors don't know, they are telling you are not going to walk. So this is a part and parcel of just like any other specialty. Thank you, sir.
Thank you. So nice presentation, Dr. Abhinav. Most of the untold things in our PMR practice as far as sexual rehabilitation is concerned, you presented a very nice way. So I hope our participants must have gained a lot of things from this presentation, especially the slides were very good. So thank you, and thank you for accepting our invitation and presenting a nice talk in this webinar. Let us see whether any questions in the chat box.
explain the slide of level of injury. Could you please, Dr. Nagma Senam has asked, sir, could you please explain the slide of level of injury and reflexes importance? Okay, this level of injury, as I told you, T6 is an important thing in a spinal cord injury. Any patients with a spinal cord injury, T6 becomes important. Okay, so T6, why T6? T6, the moment we see T6 and above, we have to always, one thing that has to be in mind is AD. Patient can develop AD. Another thing is this T11 to L2, that is the sympathetic supply. And that helps in the ejaculation part. So whenever we are managing any patients with a spinal cord injury, sexual matters, erection and ejaculation has to be in there. So if sensory part is present, that means incomplete injury is there, then psychogenic aspect will be present. And even if it is higher up, even if it is higher above T6 level or even L2 level, so it will be beneficial. Now, whenever we look into the bulbocavernous reflex and the sensory and the motor component in the sacral part, the one thing that is in whether it is a complete injury or an incomplete injury. So if it is a complete injury, reflex part, that means if the sacral S4, S5 sensory is absent, BCR is absent, that means sacral plexus is compromised. That means parasympathetic part is compromised. So that becomes important. Another aspect is, if with the level of injury, if you look with the level of injury, the other component that I said is the balance. So someone who is a cauda equina, his level of balance will be better. Someone who has level of injury at around T10, so his lower abdomen will be paralyzed, upper abdomen will be better. Someone who is at T6, his abdominal component will be compromised. So we have to work on it. If someone is having cervical injury, then again hand component will be compromised, the sitting balance will be compromised. I'm talking about mainly those who are complete injury. So if hand component is compromised, you need to do lot of things during the sexual part with the hand also. So that part has to be worked on. Another thing that I do advise to the patients, which I missed to mention that point of time, was that you can also plan for a masturbation in a different type with your partner. If you're a female, you can try with the hand and the finger to so that she gets an orgasm. Orgasm becomes very important. I hope I am clear. Another question. What are the long-term side effects to be kept in mind of patient on oral medication? Okay. One thing that has to be kept in mind is, again, as I said, all complications of spinal cord injury has to be kept in mind. One of the common problem with these oral medications is, if you remember the history is it was started for some cardiac patients. So these cardiac patients, orthostatic hypotension is one of the important risk factors that has to be always kept in mind while prescribing any of these oral medication. So because this oral medication, the BP may nitrous oxide will be released and BP may come down. This is an important thing. And if someone with a compromised trunk balance and or any balance, orthostatic hypotension is happening simultaneously, then it may be there. Another thing is blushing and redness of the skin. Then other side effect can be, that is sensitivity part, whether it suits him or not suits him. Some may complain of nausea. That nausea can be because of the high dose or orthostatic hypotension. That is also another again problem for it. And again, this muscle ache and muscle pain with the tadalafil has to be always kept in mind.
Somebody asked about the doses of tadalafil.
Tadalafil, sir, we do start with a low dose, 10 mg. 10 mg it works, and then we wait for it, and it is always an individualized treatment. then we can, this patient about which I explained, I went up to 50 mg, but it did not work. Sildenafil, we can go up to 200 mg. Vardenafil, I have not tried practically, so I don't have a much of an idea. These two we commonly. Another thing that I do prescribe tadalafil is, because this is something keeping this social taboo that is behind it. Because if a female goes to the shop, and most of the patients are not able to go to the shop, so if you prescribe tadalafil, they will find it convenient that may most of the time shopkeepers don't know, but about sildenafil, they may make some comment or pass some comment which is nasty for the patient's or couple's life. Anything else?
Some of the questions, few questions earlier might not have seen these things.
How does one initiate counseling the patient if they are hesitant to talk about it at first? Now, this is a very good question. Dr. Megha Bhargava has asked. Initiating a talk is first a comfort level of the patient. What I do is, most of the time, Indian custom, or you can call it cultural effect, female are not comfortable talking in front of male about the sex. It is mostly the mother or the friend and the husband who, or the husband who which they are comfortable. So what I do is, I don't discuss in the first session. I don't discuss about sex with them. I do give them hint only. Okay, there are other issues. I know you have a bladder problem. आपको ब्लडर का प्रॉब्लम है, पेशाब का प्रॉब्लम है, और जो भी प्रॉब्लम है रिलेशन का, परिवार का, सारा का प्रॉब्लम हम धीरे धीरे स्टेप बाय स्टेप सॉल्व करेंगे. दिस इज हाउ आई इनिशिएट. So I just give them a hint that okay, that part of solution is also there. What happens many a time that these patients will come alone and say, sir आप उस दिन बोले थे कि ये वाला part है, ये वाला part है, and always keep this thing. Give them a hint. Don't open up. Give them a hint. Physical relation भी आप अच्छा बना सकते हैं, कर सकते हैं, हमारे पास option है. So most of the time, this is how I start. I don't go for a first session. I don't sit and tell them. I said them, see, mobility is important, life is important, and everything is important. Just like your career, every aspect of your whatever spinal cord is affecting, we do take care of it. So another. No, there are any fellowships in sexual rehabilitation in India or abroad. Dr. Indrajit, I don't have any idea about it. Whatever I learned from CMC Vellore, and I am practicing it, and I got free hand to work in IJMS. So during my residency, this is my experience. If some of the senior faculties can talk, can explain this fellowship, I don't have any idea. One more thing about this fellowship I would like to add. I am a member of International Association of Sexual Practitioners. So they do a basic course. So I keep attending their conferences and seminars, and I do learn a lot of things from them. So that is called IASPMM is there. So once in a while they will also have webinars. So that enhances me so that I can compare. I have some idea about how they are managing the normal patients. So with that part, comparing to these type of patients, I do work on it. I did a basic course from that association, and that is working. What are the long side effects to be kept in mind for patient on oral medication? Okay, we have done. Waiting for, I learned a lot. Nice presentation. Thank you, Muralidharan sir. One can
I
talk
think there's no
because
more questions.
yes, sir, sure.
Relevant questions.
Okay, sir.
So if there is no more relevant questions in the chat box, we can conclude the session with a big thank to you, Dr. Abhinav. Very nice presentation, and the way of your way of presentation is really excellent. And
Thank you,
we
sir.
also expect some more topics on from spinal cord injury from your experience in the work in the CMC Vellore. We'll expect
Sure.
some more presenters in the future also.
Sure, sure, sure. Okay.
Thank you all attendees who have joined the webinar. And I must thank the office bearers of IAPMR supporting us by providing this Zoom platform for conducting such academic webinars for our students, for the young physiatrist. So thank you all senior members. So I can see that Dr. Muralidharan has joined also. So I thank everybody for joining this webinar. And once again, thank you very much, Dr. Abhinav, for your
Thank you, sir.
wonderful presentation. Thank
Sure.
you. We
Thanks, sir.
can close the